Welcome to Dr. Gio's podcast. I am your host, Dr. Gio, where it is my intention to help you with your prostate health and live better with age. Today, we're going to talk about tissue-based biomarkers for the risk stratification of prostate cancer. What are we talking about here? Dr. Gio, can you speak in English, please? Yes. Here's the deal, folks. Some guys need to get a prostate biopsy, right? And once you get a prostate biopsy, you get this tissue, little samples, cores of the tissue, of the prostate tissue, to learn some genetics of prostate cancer, if that's what you have, to learn more information about your prostate health. Or after a prostatectomy, so after the prostate is removed, then you can look at, you could do genetic type of testing for the whole prostate to have an idea of what is your risk of, let's say, getting prostate cancer recurrence within 10 years' time, right? So that's what we're talking about today. Tissue-based risk stratification for prostate cancer, right? Now, here's the deal. You have several scenarios here, right? One scenario is, okay, you get a prostate biopsy, and that biopsy is negative for prostate cancer. Can you take that for face value? The reason why you got a biopsy in the first place is because something indicated that you need a biopsy, that you have a risk of prostate cancer. Something indicated that you might have some abnormal cells in your prostate, whether it was a constant rise in PSA or a prostate exam that showed that you had a nodule, or both, right? So you get the biopsy, and the biopsy results come back as, nope, there's nothing there. We couldn't find any cancer there. It's negative for prostate cancer. Can you take that for face value? Right? And the reason why that's important is because there's something called undersampling in prostate biopsies. Undersampling. What does that mean? That means that they took 12 or 16 cores of your prostate, but they might have missed the actual tumor. Okay? They might have missed the actual tumor. If someone was to take 100 samples of your prostate, pick out 100 cores, that's only about 1% of your prostate. So it's really difficult to know just from a biopsy, can we take this biopsy result for face value? Now, it's important to know that the only one way, the gold standard way today in 2023, and probably I'll be saying the same thing in 2025 and 2030, to learn if you have prostate cancer is through a biopsy. There is no other technology. There is no other method. Okay? There is no imaging that can say, yep, you have prostate, and that's a diagnosis. The only way to learn if you have prostate cancer is through a prostate biopsy. Period. End of story. Okay? That being the case, it's not perfect. Even a prostate biopsy is not perfect because this undersampling scenario where it could be missed. The tumor can be missed. So what we want to know is there any technology, any test, any genetic test that we can do to confirm that we indeed don't have prostate cancer after a prostate biopsy? Because here's the other deal. You're going to have to undergo a lot of biopsies, maybe one or two more, to confirm that indeed that first biopsy was negative for prostate cancer. Nothing was there. So typically in most clinics, the next biopsy would happen in about 6 to 12 months after. Some studies indicate that you can do it you could do it even 24 months after that second biopsy to reassure that that first biopsy was indeed negative. All these biopsies, no one wakes up in the morning. I always say no one wakes up in the morning saying, man, I can't wait to get that next prostate biopsy. Whoa, I can't wait, right? No one does that. The good news is also that a lot of institutions are doing these MRI guided biopsies or MRI targeted biopsies where there's less likely of missing important tumors, right? You kind of the suspicious lesions in the prostate are they kind of pop up on imaging, and the urologist can target that area that looks really suspicious. So as a result of these MRI targeted biopsies, there's just less false positives. Still not perfect. Still, even with MRI targeted biopsies, about 30% of either tumors or significant tumors, those that are of a higher risk, can be missed. So that's why there are these genetic tests, right? And the first one we're going to discuss is if you get a biopsy that says no cancer, you want to make sure that that's indeed the case. And there's a test called the ConfirmMDx. Your urologist would have to order that test. And what they would do is they would take the biopsy tissue and do some genetic testing on that biopsy tissue. How it works is actually a little complicated, and it's going to be a story for a different day. But today's podcast is for you to know that if there is a negative biopsy that comes up with a negative result, you don't have prostate cancer, you're not sure, you can do this ConfirmMDx to ensure that indeed there's low likelihood of something being missed here. Low likelihood, highly unlikely that we're missing something. And the other reason why that's helpful potentially is because then you don't need to perhaps even get another subsequent biopsy, all things being equal. PSA stays stable and no nodule on your prostate and things of the sort. Okay, so maybe you don't have to undergo another biopsy either in a year, either 2 years or at all. So that's the ConfirmMDx. Is a conversation you need to have with your urologist and ask them about it if your test is negative. Okay, so now, what if you do a prostate biopsy and the test is not negative? The test is Gleason 6, right? So Gleason 6, for those in the know, and if you don't know, great. That means you haven't had to deal with this, or you're not worried about this. But if you know about prostate cancer, that means you've dealt with this or you're dealing with this now. So this information is pertinent for you. If you have a Gleason 6, right? A Gleason 6 prostate cancer, it's what's considered a low-risk prostate cancer. Low-risk prostate cancer, if you die, whenever you die, you likely die with it, not from it. That's what they say, right? And you might be a candidate for active surveillance, right? So that's great. There again, if you get a prostate biopsy and comes up with a Gleason 6, you want to ensure that that's indeed the case. That there's nothing else. There's no Gleason 8s out there, right? I had a patient recently who had a Gleason 6 prostate cancer. 3 cores out of 12 Gleason 6. His GPS, so one of the tests that measures these low risk cancers that are diagnosed from biopsies through the genetic testing, is called a oncotype, or GPS, genetic prostate score, GPS. So the score goes from 0 to 100. And this patient had a Gleason 6 on biopsy. When we did his GPS was like 50 or 60. That's a bit high. So remember, GPS score goes from 0 to 100, 60, which means it's probably something there that's higher than a 6. This is an African-American male, right? So we know that African-American males are at a higher propensity to succumb to prostate cancer compared to all other races and ethnic backgrounds. Young. He's 49. In most men, I recommend active surveillance in men, at least in 6, right? His PSA was, he's 49 years old. His PSA was like a 7.2. We did a GPS test. His came out like 61, bit high. He decided to undergo a prostatectomy. So he got his prostate removed. Now, here's the other thing that I need you to know. The only way to know if what's going on in your prostate, so if you have cancer in your prostate, the only way to know where the cancer is, what kind of cancer, what Gleason score, what stage, right? So Gleason score is a staging system. What is by removing the prostate, kind of slicing it up and looking at it under a microscope. That is it. Of course, no one will undergo a prostatectomy, removal of the prostate, just to know what they have, but that's the only way to really know. Second to that is a biopsy, and a biopsy is the gold standard way of diagnosis. So with this gentleman, African-American gentleman, it turned out that once he got his prostatectomy, the GPS test was correct. His Gleason score was upgraded from a Gleason 6 to a Gleason 7, 3+4. Okay, so that was, I think, and if that test would not have come back with such a high GPS score, perhaps we would have said, all right, maybe you're good for active surveillance. But it turned out that it was a good move for him to get his prostate removed, and now, of course, he's doing a very aggressive lifestyle interventions with exercise, nutraceuticals, diet to keep himself well and to not have a recurrence. So the Oncotype DX or GPS test is a test that we used by Genomic Health. It's also the sponsor of today's podcast. But there are other tests that we should mention. The other test is the Decipher test. So with the Decipher test, you can also get biopsy tissue, send it away, and that would come back with a GC score, And that GC score is from a scale of 0 to 1.0, right? 0 to 1.0. And so there again, the higher the score, the higher the likelihood of there being something else going on in the prostate, right? So maybe it's not a real Gleason 6, right? And that's the Decipher test. Another test is available for biopsy tissue testing. It's the Polaris test. There again, there is a panel of 31 genes that it's looked at. 31 genes to determine what is the genetics of that tissue, of that Now, this is a whole lot different than where we're talking about genetics that's passed on from your parents, right? So I believe in other podcast episodes, we've spoken about, this BRCA1 and BRCA2 and other tests for, that is like a saliva test to see what is your genetic overall risk for prostate cancer or any other cancer. This is very specific to prostate cancer. Okay. So the Polaris looks at about 31 genes, and it's not worth going over what these genes, the name of these genes, because they are filled with letters and numbers, LASP1 and IQGAP3 and so forth. So we're not doing that. We're not doing that. We're just focused on what do you need to do after you get your prostate biopsy and what kind of conversation you should have with your urologist. So the Prolaris test is another test that's used when there is when the biopsy tissue says it's positive with a Gleason 6 or low risk Gleason 7, 3+4. Okay. Two other tests that are available, I believe are available, I have not used them, is ProMark. ProMark gives you a ProMark score in a scale of 0 to 100. They look at other genes, about 8 protein genes, to see risk of perhaps having a higher grade prostate cancer than what's shown in the biopsy. Okay. And another test is called the P10 TMPRSS2, which I am not sure that this test is currently available. But there again, it looks at P10, which is what's called a tumor suppressor gene. So we have certain genes in our system, in our bodies, that get rid of cancer cells, right? That's their role. Their role is to, when these cells from these genes, they look at cancer cells that look abnormal, they get rid of them. So our bodies have tumor suppressor genes, but sometimes we don't have these tumor suppressor genes like the P10 gene. So this P10 deletion will increase the risk of prostate cancer and aggressive prostate cancer. That's another test. That, there again, I'm not sure that's available today in March of 2023. So the three that are most commonly used are the Oncotype by Genomic Health, the Decipher test by Biosciences, and Prolaris test by Myriad Genetics. Okay, the ConfirmMDx test is also by MDx Health, and actually the GPS test is also by MDx Health because they merged. So the confirm test, biopsy is negative, and you want to confirm that that's indeed negative, then you do a confirm test, or at least you have a conversation with your urologist about it. If it comes up positive, Gleason 6, Gleason 7, then you either do a GPS test or a Decipher test or a Prolaris test. Okay? Now, you get a prostatectomy. Your prostate is removed. Are there any tests that can look at the prostate itself to look at what's the risk of recurrence within 10 years? And there are two tests. One is the Prolaris test, so the same test that looks at biopsy tissue, and the other is the Decipher test, the same test by Biosciences, Genomics DX Biosciences, that looks at biopsy tissue. They can also get the prostate, look at the prostate under a microscope and say, okay, here's the risk of our biochemical recurrence within 10 years. It's the same score for Decipher is the GC score, 0 to 1.0, and it's the CCP score for Prolaris, 0 to 6. Okay? Now, here's the choke point. The choke point is that your urologist may not be into ordering these tests because they're banking on the pathology report. So, or they are focused on their methodology. So if they, some urologists who do, for example, MRI guided biopsies, they trust that the MRI guided biopsy and the result of that biopsy is what it is, and that gives you the risk stratification of that patient. Okay? or they're just not into it. I've had numerous conversations with some urologists, and they just don't order it. For example, if they order a I've had this conversation recently with a urologic oncologist, where he would not order a GPS test on a patient's biopsy, because he says, "Look, if it's low risk, is low risk, and now it's that number's coming higher, and now we have to do something with that information. We have to perhaps rebiopsy or remove the prostate. I don't know. Look, I think that in my practice, and what I recommend to other practitioners when I'm training other practitioners, is more information is better. Some people think less is more. I'm a less is more type of guy as it relates to treatments or too many invasive procedures. I am a more is more type of guy as it relates to knowing more about my body and my genetic risk. Ignorance is not bliss in my mind. So I want to know as much as possible. So I think that if there's a negative biopsy scenario, I think I want to know my ConfirmMDx, right? I just want to make sure that this is a true negative biopsy, that there's nothing missing. If I have a low risk prostate cancer biopsy result, or a low intermediate risk or intermediate risk, I want to get an oncotype or GPS test, same thing, or Decipher or Polaris. If I have my prostate removed, I want to get a Decipher test, or Polaris, to give me more information on what's my risk here. Now, how does that information help? That information in terms of what's your risk after a prostate, let's say a prostatectomy, a prostate removal, helps in two ways. Number one is you may need a follow-up therapy after that, like radiation. Maybe if you're tinkering around, getting radiation, it also depends on your biopsy results. On your pathology report results once you get your prostate removed. Right. So that pathology report, if it shows that there is positive surgical margins and so on, and then your PSA starts rising, some people would say, look, I don't need a Decipher or Polaris there. I'll just treat with radiation. But maybe you don't, depending on the results from a Decipher or Polaris, or at least not start radiating right away. Right. It can guide the practitioner with your partnership. Remember, as a patient, you are a partner to the practitioner. You are a proactive participant in your own healthcare, or at least that's the way it should be. And there lies another reason why I think these tests can be helpful. The other way it helps is it can help to encourage you to be more consistent with lifestyle measures. Let's be honest. You need more information, and you need more. You need to be. Most people need some sort of encouragement to live the lifestyle, right? Exercise, diet, nutraceuticals, and things like that. And if your results are not great from one of these tests, then you're going to be more diligent and compliant with lifestyle medicine, as I call it, right? Well, Dr. Gio, I already got diagnosed with cancer, and that's all I need. I don't need more. Is great. I know that that's the case. But still, this information can be helpful. Also, this information, and this is experimental. So let's say you do an Oncotype DX, right, or GPS test, and it shows, it's the score in a GPS score of 0 to 100. Let's say the score is low, 15, 10, low risk. Or intermediate risk. Let's say it's, 20, 30. But you decide not to get not to get it treated. You're going to be in active surveillance. Then 2 years later, you get another biopsy, and you were really good with your lifestyle medicine approach. You were great. You lost the weight. You exercise every day. Your diet is on point. Nutraceuticals. Your sleep is pretty good. Now you're creating a microenvironment that's hostile to cancer. So then 2 years after that first biopsy, you get another biopsy. The results come out the way they, let's say there is the same, but you get a GPS and that GPS has dropped. That's experimental. I think based on other tests that I've done, I think that aggressive lifestyle interventions is medicine against prostate cancer as well. I'm not saying that you don't need to speak to your urologist. I'm not saying that some of you do not need to undergo treatment. That's not what I'm saying. I'm saying that in some cases, low risk, low intermediate risk, when you practice aggressive lifestyle interventions, I think it might do something to the genetics and the results of some of these tests in a favorable way. That's my opinion, has not been proven. And it would be very nice to show that as I collect more information, clinical information, and see if there's anything there where there is a more favorable result of any of these tests, tissue biopsy tests, after my patients apply aggressive lifestyle interventions. So that's it for today, folks. Tissue-based biomarkers for risk stratification for prostate cancer. Talk to your urologist about it. They may not bring it up. Okay, they may not bring this up. Okay, and when you do bring it up, they may not be into it. Some urologists are not into this type of testing. I would respectfully differ in that opinion. I want to know as much information as possible on what I have or what my patient has. So have a good conversation with your urologist about these tissue-based biomarkers, genetic biomarkers. All right. This is Dr. Gio signing off. I'll talk to you next time. Thanks for tuning in to this week's episode of the Dr. Gio podcast. You can watch all episodes of this podcast and much more by subscribing to my YouTube channel on youtube.com/Gio Espinoza ND. If you love what you heard today, you can help by leaving a 5-star review of the podcast on Apple and Spotify, as each review helps us reach more men who are serious about improving their urological health and how to function better with age. And for the latest research and actionable takeaways in the world of men's health and integrative urology, sign up for my newsletter at drgio.com. I'll see you next time.